Welcome to the Athlete's First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals. All right, welcome to episode 13 of the Athlete's First Performance Podcast. We're finishing up our pain series, and Josh has a couple case study examples of how he's used pain science effectively and maybe not so effectively, so we can learn from his patient experiences and have a good chat about it. Josh, how you doing?
I'm doing pretty well. How are you?
Good. Ready for football to start? Got the Bears playing tonight.
Yeah, I just watched the Panthers get their first win, so I was pretty excited about that.
Yeah.
Sam Darnold revenge game. Anyways, so we can jump right into it. We with this, after going over the anatomy and such of pain and the different factors that can increase the risk of chronic pain, we figured it'd be a good ending to this series to talk about how you can implement pain neuroscience education into treatment. And like you said, I'll do this off 3 different patient case studies. I'm not going to go in super detail for each one, but there's one of the case studies was not a very successful pain neuroscience education situation, and then the other 2 were, and the 2 successful cases were distinctly different. So I want to touch on both of them. So let's start with the unsuccessful one. And I wouldn't say it's completely unsuccessful. It just, there were mistakes that I made that I have done differently and learned to do differently at this point in my career. So the first patient was a male, middle age, 40, 45 or so, chronic pain for a very long time. It started out as back pain, but it spread to his neck. He was getting radiating pain intermittently down the arms, radiating pain intermittently down the legs. So you could just see that he was in this sort of vicious circle of chronic pain. A couple other risk factors, things that we had talked about in our last podcast was he was a workers' comp case. So he had the added stressors of just the case itself, and then not being able to work. His employers weren't happy with him because he was out of work for so long. And then just all of that had came to result in kind of more depressive type symptoms. He was very anxious. So he had a lot of those risk factors going for him. His evaluation was relatively unremarkable in regards to specific objective findings. There were definitely movements that were painful, but nothing where you would do a special test for or anything that would garner specific treatment for a particular pathology. It was just widespread pain. Then you had all those psychosocial factors as well. So beyond the typical physical therapy treatment, I wanted to implement pain neuroscience education. And I was very excited to implement it because we had just had this lesson in residency. So this is a patient residency. So it's first year out of school, like 6 months out. We had just learned this stuff, and we didn't get a lot of it at USC. So I was pumped to use it. One of my mentors was heavy into pain science as well. So I wanted to dive in with it. And I didn't take the time to get an idea of what this patient was comfortable with as far as and what he was willing to accept information-wise. The course of his care through different medical providers, he had so many different explanations for why he had pain. And when you start to tiptoe into the pain neuroscience education realm, it can sound very, kind of all in your head, sort of like you're basically not dismissing, but it can sound to the patient that you're sort of dismissing the physical piece of it as far as what you would typically think, like a disc issue or something like that, and putting it more on a system-wide, something that you can't really see as to why it's happening. And it's just not mainstream, so it's hard for people to understand. So I dove in and I'm sure overwhelmed him with information. I did not do that on the very first visit, but we saw each other for a while. I gave him handouts and all these different things, but the biggest mistake was just giving him too much at once and not asking him before I did it what he may be comfortable with me giving him. And sometimes you don't even really have to ask. You can just gradually understand what the patient's perspective is with your treatment. I don't say it was unsuccessful, but it just didn't have the effect that I wanted to. I mean, we had a good relationship. He didn't not believe me per se, but it just didn't. I'm not sure that it hit like I would have wanted it to. It didn't really contribute anything to the plan of care, and I think it was because I kind of went fire hose on him as opposed to giving him little tidbits at the time. Have you ever had anybody that you've tried this with that has been a similar failure, I guess?
I haven't really had like the pain signs talk with a lot of people, just because of the patient population that I've been treating. Right now, currently in my job, that's going to be something that I definitely need to start using because there's a lot of different psychosocial factors with the people that I'm treating that are resulting in pain or just not getting better. So the answer is no, just because I haven't, just because I haven't really had much experience with it. But what would you say are some key takeaways? Like, how would you have liked to do that better? Chopping that up into smaller bits of information.
Yeah, I definitely think easing back and not going all in on the pain education piece. I had found it so interesting when we went over it in residency, and I was like, oh, this little secret weapon that we never learned about in PT school that makes a lot of sense to me. So it should make sense to the people I'm educating. So yeah, definitely chopping it up into smaller bits. And when I talk about these next two cases, I'll kind of show how it changed how I would do it. But then also there's different, I guess, routes that I've taken. And one is the straight like pain education. Like, what do you know about your pain? What has people told you about your pain? Like what are you willing to hear from me about your pain? Can I send you some documents? Can I, whatever. But there's also the route of just knowing some analogies, like we talked about that cup analogy, and just gradually introducing that while the patient's doing while you're doing hands-on or exercise, things like that, to, gradually slip it in, I guess, as opposed to making it a pain education session. So it's obviously part of a treatment. It's not all the treatment, but I think you have to decide where your patient is and what they want to know, or how much they'll accept, and go from there.
Yeah, and when you're educating the patient, are they doing stuff like are they going through their treatment or movement, or are you sitting down with them like face to face and talking through this? How do you like to start that conversation?
Usually they'll be doing things. Though that one of these cases, it was pretty much like they were doing some graded exposure type things to some fearful movements, but it was heavy education. But I asked her and she was totally down with it. Like she had picked it up and she was trying to understand it because it was something that just made sense to her based on everything else that she had been through. But yeah, typically it's during treatment, and I typically don't implement it at the evaluation. I just got to feel out the patient first.
Yeah, and I think that's important. There's not a lot of things that I like to do on that initial evaluation, just get a sense of where they're coming from and see how they move and what objective findings they have and how they respond to that initial treatment. But yeah, I'm usually pretty pretty conservative with just implementing new things at the very beginning. If it's manual therapy, manipulation, whatever.
Yeah, I think that's one of the biggest things is just kind of meeting the patient where it's at, and then most treatments will work if they, if you have a good relationship and they like you. So I mean, building that first before diving into whatever the treatment is that may be possibly out of their comfort zone is important. So I'll dive into this next case study. This one was someone who had biopsychosocial factors. So they definitely had some physical impairments that we treated specifically. And then they also had some psychosocial components that we treated with some education. But this was more of a combined treatment, which is what it should be. But it worked out well for her. So she was a 39-year-old female. She had chronic headache. She came to us direct access. Her job required prolonged sitting. I remember this patient much better, so it's gonna be a little more detailed. But so her job required prolonged sitting and phone work. She had these headaches for pushing 20 years. Began with a car accident, and then worsened after a second car accident. She had seen an acupuncturist, chiropractor. She's had medication. She had a suboccipital nerve block. She was currently being seen by primary care and neurology with a chronic migraine diagnosis. Um, Her triggers were stress, diet, weather, light, and exercise. And this was subjectively. She was hitting headaches about 25 days out of the month. So she had difficulty concentrating at work, caring for her kids, and being social. So we had to determine what type of headache that it was. We determined that there was a cervicogenic component, which we treated accordingly, just as you would based on those classifications for neck pain. And there's also psychosocial component. She was very motivated. I always find it helpful when you can reproduce the symptoms during the objective exam. So we were able to reproduce the headache during that exam. But the chronicity of symptoms was a bit of we weren't sure how well the whole treatment would go. The general PT treatment, we did soft tissue work, some dry needling, and then we did some cervical stretches and craniocervical strengthening, like deep neck flexor stuff. And then we did some environmental changes as far as sitting at work and a little bit more of like activity pacing. And by that, I mean how long she's doing a particular activity for. And then we got into the pain education. So for her, I asked her, and we built kind of clicked right away, but I asked her what she was comfortable with and what she knew about her pain, what previous medical providers had told her. And I didn't change the narrative, but I kind of gave her a bit of a reason why some of those things may not necessarily be true. And the way I did that was sort of proving it physically, I guess that makes sense. So, for example, if someone says they have back pain bending forward, but then you have them sit down and have it bend forward and it doesn't hurt, it's like, well, you just bent forward. Both ways, one hurt, one didn't. So you moved your spine the same amount, but one hurt and one didn't. So it doesn't always equal the activity, which sort of helps you drive the message home of that, just because you're bending your spine may hurt in some cases, it doesn't hurt in other cases. It typically means that pain isn't going to equal a certain movement or damage per se. The way once she said that she was okay to learn about it, I sent her some Adrian Lowe patient-friendly education documents. I didn't give her 1,000 things at once. I just gave her just the initial, like, what is pain? What's the purpose of it? What can make it last longer? And then how we can work to get out of that cycle. It made a lot of sense to her. And I think that's half the battle. If the stuff makes sense, it'll probably help. If they don't believe it or they don't latch onto it, then it could be almost detrimental as far as a relationship. But that was someone who while we exercised and did manual treatments and things like that, we also implemented the pain neuroscience education into the treatment, literally just through conversation. Like, well, if I was going to be doing some soft tissue on her neck, I would be talking to her, and obviously sometimes just talking about what they did that weekend, but other times we'd be able to talk about, how's your sleep, how's your stress level, and just reiterating the things that can help downregulate the nervous system, and trying to manage the things that can upregulate the nervous system. It took a while. It wasn't like one big thing, but she did quite well. She ended up, her headaches dropped off to like 4 a month or so. And she's back doing a lot of what she was wanting to do that she couldn't do at the beginning of treatment. But yeah, it was something where we kind of tapered. So we did this pain education, and we didn't go heavy the first visit, but it was heavier in the beginning, the first month or so of treatment. And then we tapered it off to the point where she was focusing on her goal activities. So I think it was something for her that laid a foundation of why she's having these chronic symptoms and how she can get out of it. And then we just implemented those factors. So it was primarily educate. If she picks it up, that's what she did. It was helpful. And then once she understands it, you don't really need to keep reiterating it. Just go ahead and move on and focus on the goal activities. So yeah, it was again, it's someone, if they latch on to it, it's always helpful. But with her, I gave her less information in the beginning, and I just gradually sprinkled it in as we went earlier in the treatment. And I didn't keep hammering it home over and over. Just once you learn how to do something, then just go practice it.
Yeah. Do you think it's helpful to give those handouts and them go home and just read through them at their own pace instead of you actually stating it to them? And then when they come back, they've already read it and then they can ask their own questions. Do you feel like that's a lot more powerful for the patient, or does it just depend on who it is?
I think if a patient's willing to take the documents home and read them, I think that's a good sign that it'll probably be a beneficial, like educating them on their pain will probably be worthwhile. So yeah, it's not necessary. I would say the majority of the time it's sprinkled in as we exercise or something. But if it's someone with a pretty hard, like chronic pain, psychosocial issue, where there's clear factors that can be addressed outside of traditional PT, then yeah, I'll try. And what I've done, I don't know, at some point was I made a sample email that I'll send to someone who may benefit from these documents. And I'll edit it based on their situation. There's a link in there about sleep and how that affects your pain that probably almost everybody could benefit from. But and then there's like a beginner's document on pain that's kind of like part one that I would send. So I think if someone's willing to, accept that, read it, it's like a home exercise program, then go for it. And for some people, I'll say, like, I may give them an exercise, but I'll also say the biggest thing that I want you to do is read this, think about it, and then just come back and we can talk about it. So yeah, I think that's how the education, you can't force feed it. You got to give it to them. And I'll say, how much are you willing to, if I sent you some things, how much are you willing to go over? Never had someone say no, but I probably also tailored that question to someone who's very eager to figure out what's going on, as opposed to someone who's there a little bit more because they have to be there. So yeah, I think that's ideally in a perfect situation, I would try that. Some people don't need it as much. Some people I don't think would actually read it. So that's when I more verbally talk to them about it.
Yeah. And I don't know if you've ever had this, but checking on some like those blue flags, like they're unsatisfied with their work, or they don't like their job, they don't like their boss, they don't get along with people at work, and work is one of their biggest pain complaints. Is there anything that you see in terms of the pain education going with that, or is that a whole different topic?
Yeah, that's almost when it starts to trickle into like seeing someone who is an expert in psychology, I guess, because it's super hard and it's hard for me to even just tell them, it's like, I'm not going to that job every day. So even if I say something about, like try to focus on the positives or whatever, they're gonna be like, well, you don't do this every day. And a job obviously is, I feel like, half your life. So it can make a big difference. Chatting about it for sure. Like, doesn't have to be education, but just letting them vent is great. But I wouldn't necessarily try to fix that problem, because sometimes they don't really need a solution. They just want to talk about it, which can be helpful. But if it's something that is like a primary driver, yeah, that's when I would probably take a step back and let someone who's more qualified take that. But yeah, that's one of those situations where it's sort of person to person, but it's very difficult from what I've found, when a job is the primary stressor with anything, whether it's chronic pain or like anything. And that first case I talked about was someone who the job was a primary stressor and he hated it and they didn't really like him, from what I understand. So that was probably another reason why it wasn't very successful. So yeah, that's tough. I'm sure you might see that
That's
in your
pretty much the
job.
biggest thing right now. People are unhappy with the work that they're doing, or they don't like um, what they're being asked to do, or the people that are around them. So that is the biggest struggle that we're dealing with. Just making sure that we can find ways that we can get them safely back to work, and they're more comfortable with their pain or whatever their mental state is with that.
Yeah, I think it's I mean, it's almost like way harder for you guys because they have no choice.
Mm-hmm.
Like they signed up for it.
Yeah.
But I think just, and this is outside of the PT realm. I don't know what category this fall under, but people want to have like meaning when they do something. So if they don't find a job meaningful, then it's just a job at that point, and that's what makes it hard. Um, so I don't know, seeing if they can find some sort of meaning in it, but a lot of times a job's a job, and you just do it to make ends meet. So if it's creating more stress and because of that making more pain, it's sort of a vicious cycle.
Yeah, it's definitely tough, and we're trying to figure out the solution to that right now. So if we find something, I'll keep you updated on it.
Yeah, but y'all have like mental health professionals with you, right? Eventually.
Yep, eventually. And yeah, there's multiple layers of the mental health. Like our occupational therapist is going to be big into sleep and mental health. There's contractors with mental resiliency that they put on different courses, and people that we can refer to. And then there's actual like psychologists and sports psychologists that we are able to refer to. So once we get everything up and running, I'm sure it'll definitely help on the physical side of things as well.
Yeah, it's something that I almost think if someone is in this situation, that if they just deal with a lot of the risk factors we talked about last episode, they probably don't even really need PT except to show them that they can do the things that they aren't sure that they can do.
Yeah, exactly. What we're dealing with right now, we're probably the least important person to be talking to them right now, but we just don't have the actual people in place at this moment. So doing the best that we can. So it'll get better.
Yeah,
In that
I think
sense.
the benefit, like the role that we have, is that we're just with the people longer. Like we have so much face to face time with patients, so that's why I think knowing this stuff is important. And I think it was an editorial in JOSPT or something I remember, but basically was saying like our job is to know, the whole iceberg, but the patient's only needs to see like the tip of the iceberg. So our knowledge should encompass, I mean, with any topic, but particularly with pain, like we should know how it works. We should know how it can improve, why it's there, the purpose, and we should know how to explain it. But we don't need to give the patient all of that information. Um, so when we have that face to face time, we have the ability to give them what hopefully they would need, as long as they're willing to accept it. So yeah, job stressors are tough, but like I said, if you're in a well-rounded kind of have a well-rounded care team, that's probably when it's the most effective.
Yeah, definitely. So speaking of what you were just talking about, Kelly Starrett posted something about pain a couple of hours ago, and I was reading it, and I want to get your thoughts. It might be hard to understand like the full couple paragraphs,
Actually,
but
I read
did
this.
you? Okay.
I think I saw you liked it or something, so that's how I read it.
Yeah.
But read it again. Read it again.
All right. So this is on Kelly Starrett's Instagram, or the Ready State's Instagram, Twitter, anywhere he's on social media. So what he said was, it's time for a change. Pain can't be just thought of as a medical problem. If it's too common, it's too pedestrian and a normal part of the human experience. We already don't treat it as such. People reach for whatever self-soothing methods are available and handy. Suffering, NSAIDs, opiates, alcohol, THC, etc. Pain that is so bad that you can't go to work or occupy your role in your family or society is a medical problem. With such a big gap between my quote, my knee hurts after this run and quote, disability from pain, we could probably stand to think differently about who really owns pain. I thought that was pretty interesting. I don't really have a full understanding of what he was actually saying. But what do you
Yeah.
think?
Um, no, I mean, there is a large gap between uh, my knee hurts to where, I can't function because of pain. So I think that that's a good thing to know. The who really owns pain is kind of weird. I think no, I don't know what that means, but I think it's a team effort. But yeah, I think when you get to the point where it's beyond the typical musculoskeletal injury, um, it's time to start to think about who would be the first line person to deal with that. And I think it could be anybody. They just have to have the tools to be able to explain. I think people just want to know why it's happening. So um, it probably starts with an acute issue and having a proper explanation, having proper care. But when it gets to be chronic, you can't have all these different narratives being thrown at somebody because it's not going to help. So whoever officially owns pain would be the person that is properly educated on pain and has the skills to like communicate that effectively to the individual. So that could be a PT, it could be a physician, it could be chiropractor, it could be um, primary care, psychology, whatever. It's just have to have the education. That's the unfortunate part is you may fall to somebody that either doesn't care to know or doesn't know, and then you're in the situation where you're afraid to bend forward because you might slip a disc. So to me, it's whoever has the ability to do it is the way to go, I think. But yeah, it can, it's a complex issue, I guess. That's what I'm trying to say.
Yeah, I think, like you said, they just have to understand it. So one way that I kind of think of this is the person should own their own pain, right? We should help guide them and teach them how to take care of themselves. And if it's to the point where they can't go to work or they can't occupy their role in their family or do whatever they need to out in society, that's when more intervening needs to go on, whether it's from PT, doctor, whoever.
I like
Yeah, if we
that.
can if we can give them the tools to take care of themselves, which is what a lot of his role is. He wrote several books on teaching people how to take care of themselves. So I think that's one big thing PTs need to keep on working towards as well.
Yeah, I like the patient owns the pain. Um, I agree with that. It's like I'm not going home with it. I mean, this doesn't mean you can't be empathetic about it, but they have to be, they have to take it on because if they don't, just like I said with the education pieces, two cases, that the person that was successful was willing to take it on and read the documents I sent her and talk about it and make sense of it. Um, which is pretty much goes to anything that I feel like if someone's, you know, willing to go through the process, they typically will see improvement. So
Yeah,
yeah, uh,
yeah,
it's a good point.
cool. Little
Uh,
sidetrack there, but let's hear this last case.
yeah, the last case is 55 to 60-year-old female. She came into the clinic. I was out of residency. This is probably about a year and a half ago. Um, she had chronic back and neck pain. It was a gradual onset, insidious onset. She had been through the ringer as far as the healthcare world, and her primary there were clear activities that she wasn't doing, but the objective exam didn't really produce anything specific as far as that would make treatment specific. So it was a general treatment. I basically did graded exposure where they're based on the movements that were uncomfortable on day one and then the activities that she wanted to get back to. So bridging the gap from, for example, not that this was her, but like someone has pain or worries about bending forward and they want to be able to garden. So I'm bridging the gap of getting them comfortable bending forward to the point where it's as close to gardening as possible. Um, so that was the physical therapy treatment per se. And then with her, the biggest thing that she wanted was someone to listen to her. The different explanations that she's had, she didn't, I don't really know why, but she didn't really quote unquote believe what she was being told as far as why things were happening. And I think that was due to failed treatment. So if someone says X is going on and they treat it with Y, but it doesn't get better, the person is less likely to believe that that was the cause. Um, so, and not that this is some special thing, it should be pretty fundamental, but I just listened to her, got an idea of uh, everything that she had experienced before, or as much as I could. So I sort of knew where I could come in and help. And she was super willing. I gave her a handout. And that was one I made particular. I emailed it to her after, and we didn't I think I saw her. I had her scheduled for 3 weeks later. I didn't see her for 3 weeks, but I told her to either email or call me after the first week just to check in and see how she was doing. And when she came back in for that second visit, she was doing a lot better relative to having pain for as long as she had had it. So she was excited, motivated, willing to start to push into some of those things that she was a little bit afraid to do. So we did some more graded exposure work, just getting her comfortable with the fearful movements, and progressed that. Gave her a new home exercise program, but it was, I don't know, 3 things, maybe 5 things. Then I gave her another handout. I used the cup analogy that we talked about. I used one, I guess the one that she really kind of bit down on was, did we talk about this like a circle analogy?
We might have touched on that a little bit, but just remind us again.
Yeah. So I had a whiteboard, so I just drew a circle. Uh, and the parameters were that if you're outside the circle, you may have pain with an activity. If you're inside the circle, you'll be fine. So the circle represents your overall tolerance. So she was sitting there in front of me. So I'm like, all right, sitting in a chair for, it had been like 5 minutes or whatever. That's inside the circle. You don't have any pain with that. Sleeping or whatever it was that was not painful is inside the circle. I explained that if you sit for an hour, that could be outside the circle. Gardening's outside the circle. Bending forward is outside the circle. So the idea was that if we can start to have her gradually practice some of these things that are on the edge of the circle, that circle should get bigger to where it encompasses more activities. And then I also told her that that circle size can change day to day. So that would be possibly due to not sleeping as well, being more stressed. What did you do the day before? So your circle can shrink. If you aren't sleeping well or you did a lot the day before, you may not be able to handle an activity that you could handle yesterday because you haven't recovered yet. So she really kind of, like I said, grabbed onto that, and that was the one that made a lot of sense for her. And I like to do that visually as opposed to just talking about it. So whiteboard can be handy. And then when she came in the second time, she was able to do more activities. So I drew the circle again, and all right, now you can do these activities. These are in the circle. What's next outside the circle? So yeah, that analogy seemed to help. I only ended up seeing her twice. She followed up with me a couple times. She was I think she was concerned about the cost, which is fine. She wasn't someone that you would see twice or 3 times a week anyway. So she followed up via phone call a couple times, and then like months later, and the biggest thing she said was that she was doing well, and that if she had a flare up, she knew what she could do to get back to where she was. And I think that was just her truly just knowing what's happening, and which reduces the fear, which allows her to improve her overall activity tolerance. So zero, nothing specific as far as treatment goes, manual or exercise. I never did any manual, whether I gave her some simple home exercise programs. The primary time in the clinic was education. So that was one that was pure education. You can call it pain science, whatever you want, but it started off with listening, and then just throwing a couple different analogies at her and trying to figure out which one makes the most sense.
Yeah. And that's awesome. I really like that circle analogy as well as writing it on the board. I think it's so important for people to be able to see and see that visually in terms of, okay, what are they able to do? What aren't they able to do? And how do you bridge that gap? And like you said, that changing circle. So if they're having a good day, like they're well rested, they're happy, they've eaten well, that circle expands. But if they've had poor sleep, stressed, worried about something, then that circle might be a little bit tighter and they might not be able to do all the things that they were able to do last week. So pretty cool. I'll definitely have to start using that.
Yeah, I think what I did was I had like the solid circle, then I just had like a dotted circle that was smaller on the inside, a dotted circle smaller on the outside. And then within those the separation between the solid circle and the dotted circle was like lack of sleep or whatever, which might constricted. And then what can make it get bigger was um, really just doing the things that feel good. As I think how I typically phrase it. Obviously, we know sleep and de-stress and things like that. But those are just global terms. So if she likes to take a hot shower, like do that. That could help de-stress and help feel good. So what can make the circle bigger was essentially just doing the things that she wanted to do, like stretch or whatever the case may be. And then the ones that make it smaller are the typical ones that they should be able to identify. And once they can identify it, then you just got to get them to kind of make it click in their mind. And that's the hardest part, but listening is the first step.
Definitely. And you did that on the first visit, is that correct?
I actually
Or
did.
did you do?
No, I did. I started on the first visit. We did it again on the. I only saw her twice. You know, she wasn't like cured or anything like that.
Mm-hmm.
She wasn't like 100%, but she was capable of managing on her own. And to be honest, there wasn't a lot more that I would even give her except for reassurance at that point. But I forget why I started on the first visit. I think it was just so apparent that there wasn't anything like major structurally wrong. And because there was no really mechanism of injury, um, after hearing her give her subjective and doing her objective exam, I was like, we're going to have times to be much better spent just chatting about this than me having her do whatever it is that she wants or whatever you would typically do for like low back pain, whatever that means. So yeah, I'm sure I asked her though, like what she was willing to. I think sometimes I say like, is it okay if I tell you about why your pain has been the way it is for so long? And that's someone's like, well, yeah, I mean, no one else has, or you know what I mean? So you have to have good rapport first. That's the biggest thing in the beginning.
Yeah, definitely.
So sometimes you can build that in a eval. Sometimes it takes 5 visits or whatever.
Yeah.
So
I like it because you pretty much laid out her whole plan right out in front of her with the circles. Like, what are her goals? What does she want to get back to doing? So pretty cool. I'm definitely going to start using that.
yeah, I like it. And like you said, visual is always better. So I'll wrap this up and then we can shoot with any more questions that you may have. Just about just kind of, I want to make sure that we explain that pain education is not a sole treatment. I think there was a article that said that pain neuroscience education or P&E or pain, whatever you want to talk, how you want to call it, is helpful to reduce fear fear avoidance behaviors and something else, which I should probably be more accurate about that. But it wasn't helpful in reducing pain levels. So if we know that exercise can activate that endogenous sort of inhibitory mechanisms that can help reduce pain, you can reduce fear avoidance. They can start to be active and ideally that will help them reduce the pain. The only time that it was beneficial as a sole activity was in PT school when we are educated solely on what pain education is. And that's when we have to know that we take that information, picture it like an iceberg, and we're only showing just a brief piece of that to the patient. So that can come in the form of sitting down with a handout and a whiteboard or whatever, or it could come in the form of celebrating a patient's ability to step up on an 8-inch step before it was only a 4-inch step, and explaining why that may have happened in such a short time, or just trying to demonstrate how for example, pain may not necessarily correlate with structure or a particular activity because it can change so quickly. So a lot of different ways to do it. I honestly, even though we're probably going to call this pain neuroscience education or whatever for this podcast title, it should just be just like we understand anatomy, it should just be something that we understand and we have the ability to slip it into any conversation that we have. So there's a name for it because everything's got to have a name, but it really should just be general patient education.
Yeah, I agree. I like it. So if someone's listening to this and they really want to get started with pain science and understanding how to use it in patient care, or your top 3 books or people to follow? I know we talked about this earlier, but like, who would you recommend?
Okay. So Explain Pain for sure. Greg Lehman has a good, I think it's kind of called me out on this one.
Or just names. Names are good.
Yeah. And then there's a book by Jared Hall that is called Sticks and Stones. And it is a book full of analogies that can be applied to any, really any situation pain wise. I think you can get an online version of that book. At least mine's an online version. But yeah, Explain Pain by David Butler, Sticks and Stones, and I forget what the Greg Lehman book is, but you could probably Google. Oh, it's Recovery Strategies. It's a pain guidebook by Greg Lehman. So those are 3 I use. I think I take that Recovery Strategies book and I'll just break it up into bits and pieces, or I'll just summarize it and send it to them. But then also just having at the ready different links in regards to sleep or what stress management strategies or whatever at the ready, so you can create your own handout for the patients.
Yeah, I think that's pretty powerful, just having those things ready to go. So that way you can talk about it a little bit in the clinic, give it to them at home, and then they can read it, go over it, and then talk about it next time with a little bit more in-depth questions. So pretty cool. Definitely have to start looking into more of those, like I've been saying this whole time. So hopefully start utilizing this, go through a little pain science series here. So anything else that you want to say?
No, I mean, I just think that if you can understand this piece, you should be way more comfortable in the clinic when someone is having a random pain flare up or whatever. You should be able to make way more sense. But now that you have to explain it to the patient right then, but it'll help you guide your treatments and whether you really need to stop doing something or, whether they can probably keep working through it. So definitely crucial, I think, to have a good basis in.
Yeah, definitely. So we'll wrap it up. So everyone, thanks for listening to the Athlete's First Performance podcast. If you guys have any questions about pain science education or further topics that you want us to cover, just let us know. You can reach out to us on Instagram or our website with all links in the bio. So everyone have a good night. We'll see you guys in a couple weeks.
See ya.
Thanks for listening to the Athlete's First Performance podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website. Both links can be found in the show notes.